all know it's a diffuse process. It involves various vascular beds, although the consequences upon the coronary bed and the cerebrovascular bed has greater impact, but it all depends upon which patient gets afflicted with what area of the vascular tree. And thus, our focus, our attention, and our efforts need to be actually in terms of reduction of multiple risk factors. Although as cardiologists, we at times remain centric towards the lipid issue because lipids are primarily responsible for these effects of atherosclerosis. But now the National Program of Prevention and Control actually looks at various risk factors comprehensively for the last 12 odd years. And today we are focusing on actually all these NCDs in a collective manner, because we do realize that Indians have a much higher so to say stroke rate per 100,000 person years as compared to, if you look at actually this particular reflection, the stroke death rates in South Asian countries, in India, Bangladesh, Pakistan, is actually very much higher than some of these developed, so to say, countries. So you can realize actually that the stroke rates, the coronary events rates, so the South Asian population is actually, this data is available from the West more than from our own country, and whether it is the thrifty gene hypothesis, it is the small dense LDL, it's the insulin resistance syndrome, metabolic syndrome, what is involved. We do realize that atheromatous plaques are vulnerable, atheromatous plaques rupture more often. We have data actually from the CREATE study which shows that Indians have much higher proportion of occurrence of STEMI as compared to N-STEMI, because the ratio is 60-40 here, whereas in some of the other Western countries it is 40-60. So we are a unique kind of a population with different atherosclerotic process. We do not have our own risk scoring system, but we do know that if we look at the age, the sex, the lipids, smoking, and obesity is now actually one of the more recent major risk factors which causes. So if we look at all these factors, one can fairly estimate the risk that an individual has for having atherosclerosis or one of the consequences. And so as I said, the national program actually envisaged to reduce cardiovascular diseases and hypertension prevalence significantly, but I think we are still pretty far away actually from this. Let's look at actually this article in Nature Reviews, which is this year only, by Peter Libby and his group. This is very familiar to all of you, and we all know that it is the LDL particle which, when gets oxidized actually, it gets engulfed by the monocytes, and that in fact forms the classical macrophage. The smooth muscle cell also actually contributes to the thick lipid core of a atheromatous plaque. And we no longer look at actually atheromatous plaques as fatty streaks and fibrous atheromatous plaques and ruptured plaque, but we do now look at atheromatous plaques as vulnerable and non-vulnerable plaques, because we want to know, we all know actually stable plaques are not the ones that cause acute events or which take away patients from us or cause sudden death. It is actually these vulnerable plaques, and we know rupture or erosion actually. These are almost 60 to 70% of the times rupture occurs, and 30 to 40% of the times it's the erosion. Erosions result in further progression of the atheromatous plaque, whereas it is the rupture which causes actually the plaque to thrombose and thus cause acute events. So depending upon what stage of atherosclerosis we are looking at, the markers will also have to be different, whether it is ADMA, microalbumin, high sensitivity CRP initially at the earlier stages, or troponin. So we look at these various effects, and actually what is very important is for us to know actually where the atherosclerosis is, because it's not going to be limited to the area that you look at. And so in that sense actually Doppler, CT angiography, MRI, and now we have these invasive methods by which we can detect a plaque. The concept of a high-risk plaque was looked at in stable patients in the PROMISE randomized trial published in JAMA a couple of years back, and we now know that the high-risk plaques rupture more often than the stabler plaques. Although the Western world has been able to reduce the vascular mortality rates, But in the developing nations as ours, actually, whether it is stroke or acute MI, the rates are actually the same. And so we have to look at our patients actually in a different manner. And today actually the concept of vulnerable plaque and vulnerable patients is there, because it's not just the plaque which is vulnerable. You could have a vulnerable patient like a South Asian inheritance, genetic markers, thrombogenic state. And we know that atherosclerosis today is augmented by inflammation, and so many newer agents like canakinumab and other colchicine story is well known to you. So we know it's the immune system and the inflammatory system actually which now causes significant progression of atherosclerosis. And this is actually a study which shows that within the first year, it's the target lesion events are high, actually the non-target. So there is a pro-inflammatory state at a time when patients come to us. And so it's not only actually the MACE rates are high because of the target lesions, but the other lesion, and it is this particular state, the vulnerable patient actually, rather than just the vulnerable plaque, which causes these patients to come towards us. And so we have various actually studies now which have been done. The Prospect 1 study was done in which intravascular ultrasound was used to diagnose and to look at actually the vulnerable plaque. The LRP study looked at the NIRS, the near infrared spectroscopy, to find out whether the patient is harboring a significant load of vulnerable plaques or not. And last year in Lancet actually we had the Prospect 2 study which was published, which looked at the intravascular ultrasound and also use the NIRS method to see whether the plaque is vulnerable or not. And they showed that 13% MACE rates were there in individuals who were harboring a high-risk plaque, whereas the target lesion MACE rates was 8% only in the first year. So if you are looking at the concept of high-risk plaques, which is lipid-laden, thin plaque, thin fibrous cap, and which is likely to rupture, you will be actually looking at individuals who need more aggressive medical therapy, who needs more aggressive lipid-lowering, immune therapy, inflammatory therapy, and thus this actually Prospect 2 study has laid the surface for us to be more aggressive in certain individuals while we are doing PCI in acute MI patients. Now the vulnerable trial has started, Greg Stone's group is going to do, and the enrollment has started this, in which they are not only going to look at these plaques, but they are also going to actually stent these people, and the results we'll have to wait for a couple of years, but it's a significant trial. It's more applicable to us Indians because we know some of these aspects will need to be more aggressively undertaken by us on a population basis and on an individual basis, because we know coronary artery disease vagaries are much more rapid, much more actually less understood by us South Asians. And so our methods of treatment of patients with acute coronary syndromes will need to be much more aggressive than some of the other races. Thank you.